Hey future doctors, welcome back to Vesserverse. Today we're diving into one of the most common and important inflammatory skin diseases, psoriasis. We'll break down everything from the immune pathway into the treatment ladder. So let's dive in. By the end of this lecture, you'll be able to confidently diagnose psoriasis and understand the why behind every treatment choice. This is a quick outline of what we're going to discuss during this lecture, including the central role of interleukin 23 and 17 pathway in psoriasis, identify the clinical features of major psoriasis subtypes, and we have four main subtypes that we're going to talk about each one in detail, recognize the classic signs like Auspitz sign and Koebner phenomenon, especially this one is pathognomonic for psoriasis. Describe the treatment ladder from topicals to biologics, depending on the severity of the disease. So, who gets psoriasis? Psoriasis has a prevalence of 1 to 3% of the population, and it has a bimodal distribution with two peaks. The first peak at 20 to 30 years of age, and the other one is at around 50 to 60 years of age. And psoriasis isn't just genetic, it needs a trigger, including stress, skin trauma, strep pharyngitis, especially leading to Guttate Psoriasis, and drugs like lithium and beta blockers. So we have these triggers like stress, trauma, and infection that we just discussed. What they all have in common is that they send danger signals to your immune system. Here you have a dendritic cell getting the signal, and therefore it's going to produce interleukin 23. This secreted interleukin 23 is going to go to T17, T helper 17 cells, and trigger the release or the secretion of interleukin 17. These two guys are essential in this pathogenesis, and they lead to epidermal hyperproliferation as well as inflammation. Psoriasis has major four clinical subtypes. Plaque psoriasis is the most common, guttate psoriasis, inverse psoriasis, and pustular psoriasis. This is a classic image of psoriasis. These lesions are well demarcated erythematous plaques with silvery white scales, and typically these lesions tend to have more of a salmon color. They often describe it like this. They're typically found on extensor surfaces like your elbows and knees. It's even found on the scalp, lumbosacral area as well. We have classic signs including Auspitz sign, and this is a pinpoint bleeding when scale is removed. You can see here, these pinpoint bleedings are pathognomonic. That is, whenever you see them, you diagnose with plaque psoriasis. Koebner phenomenon is another important phenomenon seen in many other diseases, dermatologic diseases, as well as psoriasis. This is where a new lesion forms at the site of a skin trauma. Another important subtype of psoriasis is guttate psoriasis. These are drop-like small salmon pink papules with fine scales that typically found in a different distribution compared to plaque psoriasis. These are widespread sudden eruption on the trunk and the proximal extremities. As you can see here on the screen, these are very small, ranging from 0.5 to 1.5 centimeters. The main trigger here is streptococcal pharyngitis, and is most commonly seen in children and young adults. So if you see a young patient with this sudden widespread drop-like rash, your first question should be, did you have a sore throat a few weeks ago? Because this is a classic post-strep reaction. Another important subtype is inverse psoriasis. This manifests as bright red, shiny, well-demarcated plaques, as you can see on the screen here. The key difference is that they lack significant scale. The reason is they are found on intertriginous areas like the armpits, the groin, and under the breasts. These areas typically are moist, so that's why you don't typically see that significant scale as you see in plaque psoriasis, for instance. The fourth subtype of psoriasis is pustular psoriasis. This is a sterile, non-infectious pustules on erythematous background. We have two forms, the localized and the generalized form. For the localized, it's also called palmoplantar, and these pustules are confined to the palms and soles, as you can tell from the name. It has a chronic and recurrent clinical course, and this can be very disabling for the patient in severe cases. The generalized form, also known as von Zumbusch, these are widespread pustules erupting on erythematous skin, often with a confluence. And the thing here is that we have systemic symptoms, including fever, malaise, and tachycardia. So it's both dermatologic plus systemic symptoms leading to a dermatologic emergency, which requires hospitalization. And we have triggers for these, including sudden withdrawal of systemic corticosteroids. And this is why, as we're going to discuss soon, we never treat psoriasis with systemic corticosteroids. If we're going to give corticosteroids, we're going to give it topical. Some other important triggers include pregnancy, infections, and hypocalcemia. As you can see on the screen here, we have the palmoplantar localized form of pustular psoriasis and the more severe one, which is actually a dermatologic emergency, the generalized von Zumbusch form. Erythrodermic psoriasis. This is the most severe form. The skin barrier function is completely lost. It's a widespread erythema covering more than 90% of the body surface area, making this a dermatologic emergency. And as you can assume, that we have a lot of terrible complications here, including hypothermia due to loss of the skin barrier, fluid and electrolyte loss leading to hypertension, high output heart failure, and even sepsis. In dermatology, you want to always look beyond the skin. The nails, for instance, are not just an accessory. These are a crucial window into what's happening in the joints. So when you see signs like pitting, signs like oil spot, aka salmon patch, like this, which is pathognomonic for psoriasis, onycholysis, the separation of the nail from the nail bed. When I see any of these signs, I want to ask the patient if they have joint pain. Psoriatic arthritis is found in 30% of patients with psoriasis. So we want to definitely look for dactylitis as well, aka sausage digits, and DIP joint involvement. Now that we understand what is psoriasis, what causes psoriasis, and what are the clinical manifestations, let's talk about the treatment. The treatment is a ladder. We start with creams for limited disease, move to light therapy or pills for more widespread diseases, and use targeted biologics for severe resistant cases. So if the case is mild, I'm going to go with corticosteroids and vitamin D analogs. If it's moderate to severe, I'm going to go with phototherapy, systemics like narrowband, UVB, methotrexate, and cyclosporin. If it's severe and refractory, I'm going to go with biologics, including anti-interleukin 17 and anti-interleukin 23, which were the main important interleukins or cytokines involved in the pathogenesis of psoriasis. So let's wrap up what we've learned so far. We've discussed the pathogenesis, and the most important things you want to remember are interleukin 23 and interleukin 17. For the diagnosis, you want to look for well-demarcated plaques with silvery scales on extensor surfaces. You want to look for clues. For instance, in Guttate Psoriasis, you want to look for strep throat triggers preceding this eruption. You want to look for nail pitting, oil spots, which suggest a higher risk of psoriatic arthritis. You want to always keep in mind dermatologic emergencies, including erythrodermic and generalized pustular psoriasis. To help you master this topic, I've created a free PDF summary that you can get from our website, visceralverse.org, for free. Don't forget to subscribe to the channel, and see you in the next video.